Hi, thanks for the invitation to speak at the CMAT Patient Education Meeting this year. My name is Dr. Xiaolan Feng. I'm a medical oncologist working at BC Cancer Victoria, and I am tasked today to discuss the cancer biomarker. What does it mean? Here is my disclosure slide. I do serve on an advisory board and have consultant roles in several companies listed here. And other than neuroendocrine tumor, I also specialize in breast cancer as well as sarcoma. Today's objectives, I will discuss the definition, the different types, as well as the properties of the biomarkers in general. And then I would like to discuss the biomarkers in neuroendocrine tumor. Additionally, I would like to focus discussing two most important biomarkers in oncology, prognostic and predictive biomarkers, and what the difference between them. Last but not least, I would like to discuss the predictive biomarker discovery and utilization in oncology and what the challenges that we're facing. What is the biomarker? The biomarker means it could be a biological or a chemical substance that present in the tumor tissues or the body fluid, such as blood, urine, or stool, or could be a biophysical entity such as imaging scans, which could provide valuable information about the current and or future behavior of cancer. Depending on the utility of the biomarker, generally speaking, there are 5 different types of a biomarker: screening, diagnostic, prognostic, predictive, and monitoring. Let's go through each one of them. Screening biomarker is to detect a cancer in the general population. In breast cancer, we have a mammogram. In colon cancer, we have a FIT test and colonoscopy. In prostate cancer, we have PSA for high-risk male. Diagnostic biomarker is used to make a diagnosis of a particular type of cancer or particular subtype of cancer. In breast cancer, we have estrogen receptor, progesterone receptor, and HER2. By these 3 diagnostic biomarker, we can make a specific subtypes of breast cancer. In colon cancer, we have a CEA, sorry, this is a little bit cut off, to make a diagnosis of colon cancer. Prognostic and predictive biomarker are the most 2 important biomarkers, which I will mention later in my slides. One of the great examples of a biomarker of prognostic, both prognostic and predictive biomarker are HER2 in breast cancer. Monitoring biomarker is we use this biomarker to monitor the disease during the journey of a patient when they're on treatment or when they're on surveillance. In colon cancer, we have a CEA. In prostate cancer, we have a PSA. The 3 most important properties of biomarkers are sensitivity, specificity, and reproducibility. Sensitivity means the rate of a true positive test. Lack of sensitivity means false positive, for which we want to avoid. Specificity means the rate of a true negative test. Lack of specificity means false negative, which we also want to avoid. I will specifically discuss the sensitivity and the specificity in the next slide as well. Sometimes when we're choosing the optimal cut point for a biomarker, we have to trade off between the sensitivity and specificity. For example, if we want to design a diagnostic biomarker for a lethal disease, we do not want to miss anybody. So we really want to have a high sensitivity. In a situation, we may have to trade off a bit on the specificity. Reproducibility means that we want to minimize the variation between different observers for that biomarker, such as among different pathologists or among different radiologists. So let's go back and talk about sensitivity and specificity. How we're choosing the optimal cut point for a specific biomarker is through a very complicated mathematical model. And I want to apologize of a lot of jargons that we'll be using here, but I will try to make it brief and try to make you understand. So in this diagram, the red dotted means it's a true positive test or responders. The blue dots means the true negative tests or non-responders. Then we drew a line, something called receiver operating curve. Each dot on this line represents the diagnostic test that from a random cohort with true positives that exceeding the random cohort of a true negative. This generates a portrait where the area of under the curve, or so-called AUC, represents the diagnostic performance of the test. So the higher of the AUC, the higher of the performance of this test. In brief, what we're trying to do here is to maximize both sensitivity and specificity, but minimize the false positive and false negative. Different ways to define different types of a biomarker. This is NIH, the National Institute of Health, defined different types of a biomarker. Type 0 biomarker means this marker will reflect the natural history of disease, and it can correlate the levels of this biomarker with patient symptoms. However, the association between this marker and the clinical course could be very loose, so they're not that useful. Type 1 biomarker means that this marker may capture the effects of a therapeutic intervention in concordance with the mechanism of action. However, the association with the clinical outcome could be also very loose, so not that helpful. Type 2 biomarker is really what we're looking for, because this will be used as a surrogate endpoint for clinical outcome. Unfortunately, in the neuroendocrine world, we really lack of the good biomarkers, meaning the type 2 biomarker or the biomarkers have the highest sensitivity and specificity. And this paper summarized all the biomarkers that we have explored in the neuroendocrine tumor, such as chromogranin A, urine 5-HT1AA, substance P, pancreatic polypeptide, pancreastatin, and several others. And only the top two, the chromogranin A and urine 5-HT1AA, may consider a type 2 biomarker and can have higher sensitivity and specificity depending on the cutoff and depending on the study, not the rest of them. And the last two, the BMP, stands for the brain natriuretic polypeptide, and CTGF represents the connective tissue growth factor, and those are only used in the situation to indicating the carcinoid heart disease. Another way to look at the neuroendocrine biomarkers are based on their utility and performance metrics. The green suggests a good biomarker, the red suggests not good biomarker. As you can see here, only the chromogranin A is the good biomarker, but still not as good as a lot of imaging scans such as the CT, MRI, octreotide scan, or gallium-68. In neuroendocrine tumor, we unfortunately do not have a screening biomarker. Therefore, we see a lot of patients unfortunately diagnosed at later stage when their cancer already metastasized to other places. We do have chromogranin A and 5-HT1AA. I repeated multiple times. We use these two biomarkers for diagnosis, and sometimes we also use this for prognostic. The higher the level of chromogranin A can indicate a higher tumor burden, therefore indicating a poor prognosis giving the caveat. We know that chromogranin A fluctuates a lot. In addition, it can be affected by multiple factors, such as medication, such as PPI, or it can be also affected by many other cancers and many other chronic medical conditions, such as chronic renal failure, chronic liver disease. We also use these two biomarkers for monitoring patients with neuroendocrine disease when they're on treatment. Next few slides, I would like to focus to discuss the two most important biomarkers in oncology, prognostic and predictive biomarkers. What is the prognostic biomarker from a patient perspective? Patient will ask doctors, how bad is my cancer? And that usually means they want to really ask for a prognostic marker and see how aggressive their cancer is. Predictive biomarker, when patient asks the doctor, do you think this treatment will work for my cancer? They're really asking for if there's any predictive biomarker to indicate what treatment can work for my cancer. From oncologist perspective, the definition of a prognostic biomarker is this biomarker is associated with clinical outcome irrespective of treatment to reflect the natural course of the disease in the absence of the treatment. So they're not useful for making therapeutic decisions. And this is an example I give you for prognostic biomarker. And here I'm showing you the Kaplan-Meier curve. The blue dotted line represents the patients without the biomarker. The red dotted line represents the patients with the biomarker. As you can see, the patients with this biomarker, they do poorer than the patients in the blue line, suggesting this biomarker indicate a poor prognosis. And depending on what treatment, what they have, and this patient with biomarker always do poorly. And even though this treatment, the patients may do a little bit better than this treatment, but regardless, this patient will do worse. So this is a prognostic biomarker irrespective what treatment they have. Predictive biomarker, on the other hand, is very specifically associated with the benefit or the lack of the benefit or potentially harm from a particular treatment. So they're very useful for making the therapeutic decision. Sometimes, as even oncologists, we got very confused. What is the prognostic versus the predictive biomarker? And this is the slides I frequently educate with my colleagues. And I want to show you a few examples here. We really have to include a proper control to figure out if this biomarker are prognostic versus the predictive. This curve is from a standard open label phase 2 clinical trial. And the blue line represents the patient without biomarker. The red line represents the patient with the biomarker. All patients receiving this new treatment, but there's no control. So the randomized phase 2 trials means that everybody gets the same treatment and see what their outcomes is. When you're first looking at this data and everybody get excited because you see the difference, you can see the patients with the biomarker seems to do better on the new treatment compared to patients without biomarker on this new treatment. But don't forget, there's no control in this study. If we actually include a proper control for this study, we can see when the patients receiving the standard of treatment, which is represented dotted lines here, and there's no difference when the patients compare with the new treatment. So regardless of what the treatments they have, the blue lines always do worse compared to the red line that represents the biomarker positive or negative patients. So this biomarker is only a prognostic biomarker, but not a predictive biomarker. Conversely, if we're looking at another example, this is again a phase 2 trial. Everybody get the treatment. And when we're looking at the biomarker positive and biomarker negative patients, and initially you will get disappointed because you see the lines completely overlapping each other. So there's no difference when they're receiving this new treatment. So people get disappointed. But again, you forget the control. If we include the control for this study, and you can see that when patients actually with the biomarker, and I want you to focus on this red dotted lines here, this is the biomarker positive patients receiving a standard treatment. They actually do worse compared to when they receiving the new treatment, which is represented by the solid red lines here, suggesting that this marker can predictive for this treatment. When patients have this biomarker, they should receive new treatment versus standard treatment. But when patients does not have the biomarker, which represents blue here, and regardless of the new treatment or standard treatment, they do exactly the same. So those patients should receive standard treatment or the new treatment. So this is actually a really good predictive biomarker. To make things more complicated, the predictive biomarkers can have quantitative interaction or qualitative interaction, what I call quantitative predictive biomarkers or qualitative predictive biomarkers. Quantitative predictive biomarkers means that when patients have these biomarkers, and the treatment will benefit all patients, but by different amount. Qualitative predictive biomarkers are very specific, and the patients have this biomarker positivity, then they can benefit from this treatment. When they do not have the biomarker, they do not benefit from this treatment. And this is an example of quantitative biomarker. In this study, they showed with proper control, the plasma IL-6 is a predictive biomarker for this new target treatment, pedophilip, versus the placebo for kidney cancer. And when we're looking at the data, and we know that all patients actually seem to benefit from this target treatment versus the placebo, but by different amount. If you're looking at low level versus the high level, the high IL-6 patients, and they benefit from this treatment, the lines separate more, means there's more benefit. But even when patients have low IL-6, they also benefit. The lines separated out, but a little bit narrow, suggesting that the benefit is a little bit smaller. But both of them are also benefit from this treatment. So this is called quantitative predictive biomarkers. Qualitative predictive biomarkers are very different. And I will show you an example here. And this is the clinical trial done many decades ago. And this is to examine a targeted drug called gefitinib versus a standard of chemotherapy, first line in metastatic non-small cell lung cancer. And before we know there's a biomarker exists, when we're looking at the whole population, this Kaplan-Meier curve showed that compared with the chemotherapy and this target treatment, and we see the two Kaplan-Meier curve actually cross each other. And we wonder what is the reason there. And several years later, we discovered that there is actually a biomarker to indicate this treatment. When we reanalyzed the data, and we showed that for EGFR mutation positive patients, they are the ones who really benefit from target treatment gefitinib versus the chemotherapy. However, when the patients do not have this biomarker EGFR mutation, so they're biomarker negative patients, they actually conversely benefit chemotherapy better than the target treatment gefitinib. So this biomarker is very helpful and indicate which patient should receive which treatment. So this is an example of quantitative predictive biomarkers. To discover a predictive biomarker is a very complex and challenging process. One of the most important considerations that I think for the development of a biomarker should go hand in hand with development of a novel therapeutics to ensure that the novel therapeutics are used for the right patients at the right time. So not wasting this novel drugs and to treat patients that you're not supposed to treat and give them only the side effects, but the benefit, and also avoid financial toxicity. But this is really easy to say than done. Sometimes in oncology, we have a novel therapeutics. We want to just to see if they're actually working for that population. And sometimes, lucky enough, we can actually identify a predictive biomarker. I want to show you an example of this. So this is an phase 2 trial looking at the study, a new drug called RAT001 to see if they have any activity in a patient with bladder cancer, metastatic bladder cancer after failed old chemotherapy. And unfortunately, this trial is it's a completely failure. As you can see, they only enrolled 40 patients, and majority of the patients do not have any efficacy, and they have a very low response rate and disease control rate. There is no publication. However, the investigators of this trial did not give up. They want to try and further identify because they see a little bit signal. There is a few or only one patient have exceptional response to this treatment, have a durable response of over a year. So they're really looking at what happened to this patient. And they did something called genomic profiling. So basically really looking in depth, what is the biology of this patient's tumor? And they identified this mutation called TSC1. And they found that this patient, when they have this mutation, they have the highest response rate and durable response. And they went back to the lab and identified this mutation, the TSC1 mutation, really is the predictive biomarker for this medication previously known as RAT001 and now known as everolimus. So one of the algorithms that I think that we can actually discover the predictive biomarker is to compare the exceptional responders versus the non-responders and obtain the tissue as well as the fluid, like the blood, the urine, the stool, and really work out the biology of the tumor. What's the difference between these two tumors? And do some fancy tests, something called omics study, and figure out is there any potential biomarker can indicate why this patient will respond to treatment exceptionally well, but not for the non-responders. And then go back in the basic science and bench work to figure out if this would make sense from the mechanistic perspective. Utilization of a predictive biomarker has many challenges. I mentioned the tissue. Tissue is the issue. Once we obtain the tissue, there's also a lot of pre-analytical variables and how we obtain and store the tissue that make a difference. And once we identify the potential biomarker, and we're still dealing with analytical validation, we discussed we have to meet all the properties of a biomarker, such as sensitivity, specificity, as well as reproducibility. And finally, when we identify the biomarker, we have to confirm in our prospective clinical trials and embedded this biomarker to prove this is a predictive biomarker that can predict the efficacy of our novel therapeutics. We're facing a lot of challenges. Should we give up? The answer is clearly no. I want to use this quote to conclude my presentation. Cancer is heterogeneous. The discovery and utilization of predictive biomarkers is key to the success of personalized medicine. Today, I discussed with you the definition the types and properties of different biomarkers in general. I discussed prognostic and predictive biomarker, which are the two most important biomarkers in oncology. What are the difference? What are the confusion? Predictive biomarkers are the most useful, but very challenging for discovery as well as utilization. We unfortunately do not have good biomarkers in neuroendocrine tumor, which is unmet need. The future directions to develop a neuroendocrine biomarkers, which I have not discussed today, is to use several biomarkers, not just a single biomarkers, but several biomarkers in combination with the novel functional imaging. I finished my talk. Thank you.